Let's hear from you, Parul.
Yes. Can I start sharing?
Yeah.
Yeah. Is my screen visible?
Yes, yes, yes.
Yeah. Thank you for the opportunity, Dr. Chitra, and it's a pleasure to be here. Uh, I would be talking, in fact, Dr. Shish Kumar has made my talk much simpler because he has given all the data regarding the astigmatism following pterygium and all. So I will be talking about pterygium and cataract in the form of sequential surgery, need financial disclosures. Many a times we see pterygium and these patients with who present with pterygium and coexistent cataract, and one needs to address both the entities in a best way so that one can have a better refractive outcomes. The question here is, should it be in one step or sequential? The surgeon needs to decide a treatment plan based on severity and placement of the pterygia, as it was highlighted in the previous talk. The points for considerations would be size of the pterygium, which would be a primary determinant for the treatment, location of the pterygium, its ability to distort the K readings, and obviously corneal topography will be helpful in looking at the curvature changes and induced astigmatism in these cases. If the pterygia does not prevent reliable K readings, one can definitely consider a combined cataract and pterygium removal to save the patient an additional surgery, as the previous speaker spoke about. The pterygia, which are large, 3 millimeter or more, which can cause distortion in the case, which are elevated onto the surface of the cornea and having recurrent inflammation, should be tackled first prior to the cataract surgery. As you can see here in this collage of the pterygium cases. Let's look at the literature. One of the article published in Indian Journal of Ophthalmology talks about 151 eyes where they looked at pterygium-induced corneal refractive changes, and they understood that there is an increase in the grade of pterygia. Increase in the grade of pterygia had significant effect on topographic indices, which improves following pterygium excision, which was also mentioned in the previous talk. They also noted that there was reduction in the corneal astigmatism, there was improvement in the regularity of the corneal surface, there was reduction in the asymmetry of the cornea in all the cases 1 month post-surgery. A similar kind of study which talks about correlation between pterygium size and induced corneal astigmatism. Here they looked at, we know that pterygium would induce with the rule astigmatism, and here they looked at the quantitative relation between pterygium size and induced corneal astigmatism using corneal topography and digital imaging. And they concluded that the lesions extending more than 45% of the corneal radius or within 3.2 millimeter of the visual axis reduce increasing degree of induced astigmatism. So the effect of pterygium excision, the other study, the same group conducted another study and looked at effect of pterygium excision on induced corneal topographic abnormalities. And their conclusions were that successful pterygium surgery causes improvements in visual acuity, refractive and topographic astigmatism, surface regularity index, and surface asymmetry index. There are many other studies which talk about the similar things. That Lean and Stern found a significant correlation between pterygium size and corneal astigmatism. They reported pterygium to induce significant degrees of astigmatism once it exceeded more than 45%. The other group evaluated the percentage extension of pterygium on cornea and found larger pterygia to adversely affect the astigmatism, asymmetry, and irregularity of the cornea. So essentially, all these studies favor sequential surgery. There is another group which looked at influence of pterygium size on corneal higher order aberrations and evaluated this with the help of anterior segment optical coherence tomography. And they concluded that increase in higher order aberrations reflected the pterygium size, and significant aberrations were induced in 5 millimeter diameter when the end exceeded 25% of the corneal diameter. So if we end up using a sequential surgery, we would have this kind of a quiet ocular surface after the first surgery, and one can go ahead with the cataract surgery in a precise manner. Just a few more slides. Advantages would be ocular surface would be stable, regular, and non-inflamed. The IOL power calculation is much more accurate for refractive cataract surgery outcomes. The patient is much more comfortable post-cataract surgery. The cosmos is better with 2 separate surgery. The recurrence is much lower as one can plant pterygium excision with conjunctival autograft and have better outcomes. As we know that this surgical technique of pterygium excision with conjunctival autograft is considered to be a gold standard. So to summarize, if pterygia are small and do not impact K readings, they can be left alone or maybe tackled along with the cataract surgery. If pterygia are large enough to adversely affect the K readings, it should be tackled separately, the pterygium first and then the cataract surgery. And some surgeons wait at least a month, but ideal time is to wait for 6 to 8 weeks before planning the cataract surgery. Thank you for your kind attention.
Thank you very much. Great speakers. Dr. Sain, I would want you to conclude on this. If at all we were to consider doing the surgery in the same sitting, don't you think there's some amount of myopic error which gets into it, which has to be factored in? When we are talking of premium surgeries, how do we do that kind of gross planning by doing both in the same sitting?
No, I think both the speakers, Dr. Paras and Dr. Shesh Kumar, covered all the points very well. I just want to add another additional element to that, in a way, indirectly to answer your question, that it also depends on whether the pterygium is fleshy or atrophic. So sometimes when you have, you're operating in a very elderly person who has an atrophic pterygium, not much traction on the cornea, your K readings are very stable and regular. And I think in those cases, you can, just forget about the pterygium, counsel the patient, and you can actually do premium IOLs with a lot of accuracy. So I would look at whether it is fleshy and pterygium, and also if the K readings are regular. As long as it is regular and it is not a progressive fleshy pterygium, I think you can plan even premium IOLs in those cases. But like Dr. Shesh Kumar mentioned, that if you are very progressive, those are coming in the visual axis. And like Dr. Paras mentioned, those are the ones that you have to take care, make sure that the K stabilizes, becomes regular over a period of time. It might take 3 months, it might take 6 months. And then if you're planning high-end IOLs, then wait a little bit longer for the K values to be stable, at least.
Thank you.